Good morning, ladies and gentlemen. My name is Najib Rahman. It's a pleasure to be presenting to you on this conference. Firstly, can I apologize for not being there in person? This was due to unpreventable reasons, and I'm so grateful to Muther and colleagues in Iraq for this first exciting conference on pleural disease and COPD in Iraq. I'm also very grateful for my colleagues Steve Walker and Ihab Badawi, who will do an excellent job, I'm sure, in representing pleural disease while you are there at the conference. Mother has asked me to present on this first, and this is a talk on pleural anatomy and physiology. Before we start, I guess it's important to talk about the importance of pleural disease. Now, I think any practicing clinician in pulmonology knows how important pleural disease is. This, however, is a bit of data that suggests that this is indeed the case. So this is a wonderful piece of epidemiology from the USA, looking at the total burden of pleural disease within the United States just in 1 year of practice. Let me just bring up my pointer. Sri Mohammadi, it's well worth a read, and it was a project over roughly a 10-year period. And this is what they showed. So they looked at the total cost of pleural disease as a proportion of all spending within the USA. And you can see here that malignant pleural effusion, 1.8 billion, non-malignant pleural effusion, so heart failure and so on, 7.5 billion. So this is an incredibly important disease area for all of us. And I think we all know that pleural disease is an important area. It's a diagnostic challenge and therefore important that we understand the area extremely thoroughly. So this is what I'm going to cover in the next 20 minutes or so. We'll talk about basic mechanisms within the pleura. It's important to understand normal physiology, and thereafter we can then understand what symptoms and physiology are in pleural disease and how are they related. And importantly, how this then translates to a treatment approach, which is pretty critical when we think about the patient presenting with an undiagnosed pleural effusion, about which you will have lectures later on in the course. So let's go straight to the normal pleural cavity then. Essentially, the normal pleural cavity contains a very small amount of pleural fluid. So calculations suggest 0.3 mils per kilogram of body weight. So the average male will have 7 or 8 mils of pleural fluid within each ipsilateral or contralateral pleural space. And pleural fluid in the normal state, in this small amount, is an extremely boring fluid. So it's low protein, it's an ultrafiltrate. It has an LDH that's less than 50% of plasma. The glucose should exactly mirror that seen in the plasma because it's a filtrate with a pH that's pretty unexciting. And it has some cells in it, but less than 1,000 white cells per centimeter cubed. And as I've said, it is an ultrafiltrate we think derived from the parietal pleural blood supply and filtered into the pleural space. Now, fluid formation we think is created by the hydrostatic oncotic pressure gradient, and the average amount that we produce per hemithorax is approximately 17 milliliters per day. So this is a very small amount produced each day. And as I've said, there's some debate in the literature about where it comes from, but it is well recognized now that it is generally the parietal pleura, which is the organ of interest. This is the part of, obviously, the pleura lining the intercostal muscles and the chest wall. And this is the largely the secretory cause of pleural effusion. There are some situations in which the bronchial circulation can contribute from the visceral pleura, and the amount of fluid produced seems to be dependent upon dependency. Hence, the more dependent areas, the lower areas, seem to contribute more than the apical areas, but this isn't particularly well studied. And this is what the normal pleural space looks like. So this is a medical thoracoscopy. For those of you not familiar, this is a local anesthetic procedure conducted by respiratory physicians. We have inserted a trocar into the mid-axillary line, about the fifth intercostal space, drained the fluid, and here is us standing on the diaphragm and looking upwards towards the apex. So the lung is here on the right-hand side. Sorry, I'll let the video go through again. The lung is on the right-hand side here, and this is what the pleura should look like. The spine is over here to the right, and here are the ribs coming out to the side. Just here is the subclavian artery pulsing away right at the apex. And you can see if you look at the pleural surface on the left here and then in front of us now, this is a see-through thing. It looks a bit like a thin film of cling film. You can see through it. You can see a few vessels, and you can easily differentiate red muscle from yellow fat. So the pleural surface, paratally at least, should be something that you essentially see through, and it's a very thin layer of cells. And what makes it up? So this is a cartoon of the basic anatomy. This is the fluid facing side, and down here is the alveolar facing side or the rib facing side, but it's the same on both sides, whether it's from the parietal or the visceral side. At the top, we have a single layer of mesothelial cells. They're attached with a basal lamina to a superficial elastic layer and then into the fat. And within the fat, we then have capillaries, valves, nerves, lymphatic vessels, and then the underlying structure to which it is welded with a deep fibroelastic layer and then tight junctions as well. So the mesothelium is an important tissue. It's a single layer of cells, as I've said. It's exactly the same, regardless of where you find it, visceral, parietal, peritoneal, or pericardial. And all of you will have read about cases, for example, of mesothelioma found in the tunica vaginalis or within the abdomen. And this is because of the identical mesothelial cell layer. But it is not a boring tissue. It's very metabolically active and covered in surface microvilli, which is typical of cells that have high metabolic and secretory activity. And this is what it looks like under electron micrograph. So this is the pleural space just here. Here is a mesothelial cell individually, and you can see these multiple microvilli at its surface. And we'll talk about what these spaces are just in a second. Now, those calculations I told you, 8 mils per adult per hemithorax, sorry, this was calculated with dilution experiments. So these were patients undergoing a thoracoscopy where the pleural space was normal, and these investigators, Noppen et al., they infiltrated a set volume of fluid with a tracer, and then they aspirated all of the fluid and measured the difference in the tracer concentration. And from that, we derived that in normality, one should expect about 8 mils per hemithorax. And we do know that the amount of fluid drainage increases with exercise through a series of experiments that one couldn't do nowadays. These are unethical experiments, as you see in here, conducted in 1933, in fact, on prisoners of war, where they inserted chest tubes into the pleural cavities, poured in fluid and made them exercise, and demonstrated that the X-ray looked better after exercise than it did before. So we think that with exercise, presumably with increased respiratory exertion, there is less fluid left within the pleural cavity. How does fluid drain? Well, small particles, it's fairly straightforward. Water and molecules are less than 4 nanometers. That easily passes between cells. But if we inject slightly larger particles, such as carbon up to 15 nanometers, then we can see them in the cytoplasm of the cells of the mesothelial layer. And therefore, there must be some form of absorption at the cell surface and then transcytoplasmic transport. So that's pretty similar to what it would be within the bladder or within the kidney mucosa, for example. And of course, we understand that the visceral pleura and indeed the parietal pleura has to be tightly sealed. Why? Because the visceral pleura forms a completely airtight layer so that you can't pass water and other substances. Now, in certain disease states, such as congestive cardiac failure, ARDS, then these mesothelial junctions can be damaged, and therefore we get a bit of fluid leak from the lung surface into the pleural cavity. And hence, if you have heart failure or pulmonary interstitial fluid, then that can move into the pleural space. But there is this interesting concept that larger particles and indeed cells, including red blood cells, which are very large, of course, more than 1,000 nanometers, they appear to be transported very easily across the mesothelial membrane. So if we inject labeled red cells into a patient's parietal pleura, they appear in the systemic circulation. And this can't be with one of the two previous mechanisms because these cells are simply too large. And I've already told you that there is a tight junction. So how on earth can a very large cell somehow pass between these areas? And we now know the mechanism, and this is the mechanism which is called the pleurolymphatic communication. So there is a complex network of lymphatics that sits within the parietal pleura, and here is an example of mesothelial cells forming a hole and then forming this called a lacunae, or a hole at the parietal pleural surface. And if we look at that with electron micrography, then this is what it looks like. And these are called pleural pores or Wang's pores. So Wang was the original histopathologist who identified these. What this allows is bulk flow from the pleura out into the systemic circulation of even large cells such as red cells. And so overall, then we come up with this scheme that a cartoon was given in this great review article in the New England Journal done by David Feller-Cotman and Richard Light before he sadly died. Over on the left-hand side here, you see the parietal pleura. Over here is the visceral pleura. The lining is the same. And you can see that the majority of fluid secretion occurs from the parietal pleura in. There's a little bit from the visceral pleura in, but overall, the majority of the drainage occurs via the pleural lymphatics on the parietal side. So, in fact, the majority of action within the pleural space is from the parietal pleural side, causing fluid formation and also fluid drainage. So when do we get pleural effusions? When physiology is disturbed. And this is a statement of the obvious, but we need to think about it just a little bit. Obviously, we will get collecting fluid in the pleural space when the amount of fluid being formed is greater than the drainage capacity. But which is the more prominent mechanism? Well, I've already told you that the normal production is only 17 mils per day, and those unethical experiments that I told you about before suggest that in fact the drainage capacity within the normal parietal pleura is 1 to 2 liters per day. So it's very much in favor of drainage. And this means that if you see even a small pleural effusion, the pleural physiology must be extremely deranged. And here's a great example. So this is a patient with a small amount of consolidation, what was described quite rightly on the X-ray as a small pleural effusion. You will all know that this means that there's at least 200 or 300 mils of pleural fluid within the right pleural space. Although clinically we might dismiss this as just a small effusion, it's not that important, it does mean that the parietal physiology on the right-hand side here has deranged very profoundly, even in order to gather just 200 or 300 mils of pleural fluid, and this is worth remembering in your clinical practice. Okay, we've done the basic mechanisms rather, so let's move on then and think about the symptoms in a little bit more detail. These are the common symptoms of patients presenting with undifferentiated pleural disease. I'll just go through them one at a time if I may. Asymptomatic, of course, is increasingly seen. So we see patients undergoing screening or having a chest X-ray, and they're found to have a degree of pleural thickening or pleural effusion. This is very common indeed. I'll come back to the rest in a second. Let's just talk about chest pain. Of course, chest pain is well illustrated in all of the textbooks as caused by potentially pleural disease, but we need to think about the mechanism just a little bit. And you will have learnt in medical school that the visceral pleura is completely insensate. So the lung surface has no pain innervations whatsoever. If you see a patient with pain, it must mean that the parietal pleura is involved. And the parietal pleura is incredibly heavily innervated and associated with significant pain if it is manipulated or if there is inflammation in that area. Now, why is that important? Because if you have a patient who presents with chest pain, you know without doing any further interventions or scans that there must be involvement of the parietal pleura, and this can become really important in your clinical practice. So here's an example, a 24-year-old man. He had a knee arthroscopy, as you can see here, and 5 days later developed sudden onset breathlessness, and he has anterior right-sided chest pain. You all know what the diagnosis is here. It is, of course, a pulmonary embolus, as you see just here with an infarction. But if he has chest pain, it must imply that the infarction has reached all the way to the visceral surface and started to cause a degree of parietal pleural inflammation. So this must be a wedge-shaped infarct all the way out to the visceral pleural surface. Here's an example, another young man presenting with pneumonia. He has profound chest pain. He's got right lower lobe and right middle lobe consolidation. If he has a lot of pleuritic chest pain, then this implies strongly that there must be, unseen on the X-ray here, some parietal pleural inflammation, and this implies that there may well be present a degree of pleural fluid. You can't really tell on this X-ray, but it is an important clinical feature. And also for malignancy, if there is a lung cancer associated with chest pain, you must then be worried about the involvement of the parietal pleura. Now, breathlessness, this must, of course, be the commonest cause of patients presenting with pleural effusion. I'll just deal with these two before I go on. So cough is a very commonly seen symptom. The mechanism is not clear in patients with pleural disease. It's thought to be maybe related to collapse of the lung parenchyma resulting in stimulation of the cough receptors, the J receptors in the large airways. Lethargy is a very interesting and very consistent feature of patients with large effusions. The mechanism is not well studied, but certainly when we drain effusions, their lethargy seems to get better. So let's talk about breathlessness and dyspnea. And I guess this is the question. Here is a patient with an obvious large left-sided pleural effusion. It has a meniscus. We have homogeneous shadowing just here. The question then is, why is this patient breathless? Of course, they're breathless because they have a large effusion, but what is the mechanism of their breathlessness? And we could imagine that it could be a number of things. It could be hypoxia, it could be VQ mismatching, it could be compression of the lung and lack of lung function, or it could be something else. And understanding why this patient is breathless is really rather important for our future clinical practice. So if I turn the question around, not why is the patient breathless, but when you do a thoracentesis, why does the patient feel better? And in fact, we do know that 90% of people having a large volume aspiration feel better after the aspiration. So why may it be that the thoracentesis improves breathlessness? Let's think about the theories that I suggested. So first of all, hypoxia and blood gases, or sort of lung function rather, first of all. We know from studies that draining effusion, if you drain a liter of fluid, you gain around 200 mils in the forced vital capacity. And all of you will know that a gain of 200 mils is really rather modest against a total FVC of about 5 or 6 liters. Despite that, the patient feels enormously better, so we feel that the gain in lung function is unlikely to be the main cause of their feeling improved. What about improvement in blood gases or VQ matching? Well, in fact, if you come to thoracoscopy, where we completely drain the pleural space and allow a large pneumothorax to occur, in fact, the hypoxemia gets a bit worse in the short term and not better. And as you drain and re-expand the lung, the hypoxemia will get worse because of increasing intrapulmonary shunting. And yet the patient feels better. So the PO2 we think is the same or goes down, um, and yet the patient feels better. So again, hypoxia or VQ matching is probably not the key mechanism. So here are the two proposed mechanisms. The first is effects on the diaphragm, or rather on the respiratory pump. So the presence of the uncompressible fluid within the thorax has a profound effect on the soft diaphragm, which is trying to move. It expands the chest wall and gives hyperexpansion on that side, essentially. And what we have now recognized is that patients who are very breathless, they have a profound effect on their diaphragm. So if the diaphragm is moving normally or is normal shape, often they're not breathless. As soon as the diaphragm starts to become an abnormal shape, and I'll show you that in a second, or if it becomes inverted and doesn't move with respiration, these patients tend to have profound breathlessness, which is helped by your thoracentesis. There is a second mechanism, which is a theoretical mechanism. So these are based on animal data where they intubated the pleura and also put in a right heart catheter. And they used these to show that as they loaded the pleural space, at some point, the intrapleural pressure becomes so high that it compresses the right ventricle and one gets a tension type situation. I think I've seen this in my clinical practice a few times, but over 90% of breathlessness is due to effects on the respiratory muscle pump. And why does this matter? It matters because when this patient comes to see you with a very large pleural effusion, undiagnosed for now, the reason they've come to see you is dyspnea. And in order to relieve them of the dyspnea, all you need to do is to reduce the intrapleural pressure. Now, what that means is you need to achieve enough drainage to allow the diaphragm to go back to its normal function, but you do not need to drain them to complete dryness to relieve their breathlessness. You may need to drain them to dryness for other reasons, if this is pleural infection, for example, but if it's malignant pleural effusion, a short-term reasonable procedure then is a large volume pleural aspiration. And I talked to you about proof, if you like, of how important the diaphragm function is. So this is thoracic ultrasound. I know that my colleagues are doing a seminar on this with you tomorrow. Let me just go through the picture. My probe is here on the chest wall. We're roughly in the right mid-axillary space, about the fifth intercostal space. Black is fluid, and the head of the patient is to the left of the picture here. The foot of the patient is to the right, just here. So there is a very large pleural effusion. It has compressed the lung. This is the poor lung here, which should be expanded all the way up to there. And it's completely compressed by the pleural effusion. But look at the diaphragm shape. The diaphragm should be convex upward. It is in fact flat and convex downward. So this is a completely inverted hemidiaphragm. And not only that, but on inspiration, which is that movement there, and again, more inspiration there, it is moving paradoxically. So it's moving upward on inspiration, when of course it should move downward on inspiration. So this patient we would predict is extremely breathless. We would also predict that drainage will help their symptoms. And this is the post-drainage ultrasound. And you can see here the diaphragm has come back to a nice, normal, beautiful conformation, convex upward. As the patient breathes in, the diaphragm is now moving normally. Now you can see we have left a significant amount of fluid in the chest. And in fact, this is the complete compressed right lower lobe. So despite the fact that the lung still remains compressed, the diaphragm has come up to a normal shape, and this patient felt much better. And so I think this is direct proof that improving the breathing mechanics is how we improve breathlessness in patients with pleural disease. And this is a reminder of the problem with chest X-ray. So this is a chest X-ray showing a very large left-sided pleural effusion. All of us would recognize that. The problem is we, in our mind, think that the left hemidiaphragm is probably reflected where the right hemidiaphragm is. So we assume the diaphragm is somewhere here. And in fact, on the CT scan, you can see that the effusion has had such profound weight effects that it's completely flipped the diaphragm just here. The other thing I will point out is if you look between the ribs on the left-hand side here, it's much wider than it is on the right. So the thoracic cage has been stretched, and that puts it into an abnormal conformation, and that is why the patient is extremely breathless. Okay, let's take this particular case then. Our next case, a 54-year-old man, he's fit and well, he presents breathless, obviously with a very large pleural effusion. But the question is, what would you predict the respiratory rate would be, and what would you predict the oxygen saturations would be? And this again is an important practice point. So in fact, we would predict the respiratory rate would be high because the weight of the effusion is causing tachypnea, but we would expect the saturations to be not quite normal, but at least up there and fairly normal. So with a respiratory rate of 90, this patient had saturations of 94%. So how does that make sense? Almost the entire right lung is compressed, and yet the saturations are well preserved. And this is the reason. So this is obviously a thoracic CT scan. There's malignant pleural deposits here in this poor gentleman, large right effusion, and here is the whole of the right lung, which has been completely compressed and lost all of its volume. And not only does it lose its volume and therefore its ventilation, but actually all of or most of the perfusion is diverted to the other lung, and therefore there is no VQ mismatch. There is a match defect within the right lung. So this is almost like a short-term pneumonectomy. You're pushing all of the blood to the other lung, and that's why patients, they're tachypneic, but they can defend their saturations really rather well. And if we look at ultrasound, we can see the same thing. So this is a very large effusion in this patient again, and this is the whole of the right lower lobe, completely compressed down and losing all of its volume. And if we look at thoracoscopy, oh, sorry, I don't have the thoracoscopy image there. Now, let's take the same case, same man, 54-year-old, fit and well, he presents breathless. This time the saturations are 88%, so this is lower than we would expect. The question is, how do you respond to this? Is the low saturations due to the effusion? And the answer is, it may be contributed to by the effusion, but whenever you see hypoxia with a unilateral effusion, you must think about the other lung. And in this particular case, this was a new presentation of a large malignant pleural effusion causing a pulmonary embolus on the other side. Other things that could cause this are if they have undiagnosed COPD or ILD or pulmonary hypertension, for example. Okay, let's just move forward then and the relationship between symptoms and pleural effusion. So this was a study that was done here in Oxford. This was the first attempt to quantify breathlessness and symptoms pre and post pleural interventions. So I'll just show you this graph. This was the change in breathlessness over 100 millimeters. So 0 is no breathlessness at all. 100 is the most breathless patients have ever been. And this is how much we change breathlessness by doing a therapeutic thoracentesis. On the x-axis here is the amount of milliliters of fluid that we drained with the therapeutic thoracentesis. And you can see that there's basically a linear relationship between how much they feel better according to how much fluid we withdraw. So what is the minimum amount of fluid you should withdraw to make someone feel better? Well, we can answer that with this. So the minimum clinically significant difference, the change that matters in this particular scale is around 20 millimeters. And you can see here that all patients who were drained above 500 mils, they had that improvement. So 500 mils is the minimum that we would suggest. Now, this particular piece of work has been taken forward by my colleagues in Australia. So this is Gary Lee's group, and this is a great study, the largest study looking at symptoms and pleural effusion, called the PLEASE study. What did they do? They took 145 patients who were undergoing therapeutic aspiration, and they did a number of assessments, pre-drainage, post-drainage, and up to 36 hours post-drainage. And that include breathlessness, quality of life, physiological measurements, radiology, and spirometry. So this is their main outcome. And let me just explain this is the pre-drainage column here, the post-drainage column here, and then the p-value for the difference just over here. So the first thing to show is that patients get much better having had drainage. So in Australia, the VAS works the other way around. They started with 44 millimeters of breathlessness, and that improved to 72 after drainage. And indeed, it was absolutely mirrored by other measures of breathlessness. So you may be familiar with the dyspnea 12 or the modified Borg. So that's pre and post 6-minute walk test. In all situations, draining the effusion helps patients enormously, which is great news. It also results in an increased 6-minute walk distance. But can I point out that their pulse rate goes down a little bit, their respiratory rate also goes down a little bit, but their saturations, as we predicted, do not change at all. 95% and p-value is negative. There is a modest change in their FEV1 and FVC, again, in the region of 200 or 300 mils, not much more than that, but this isn't particularly significant in terms of what we would expect of the physiology. So this study really demonstrates all of the features I was teaching you about why pleural effusion causes patients to be breathless. Within their study, they also looked at what predicts patients feeling better, and they showed that the more breathless you were before the procedure, the more you benefited. That makes sense. And then the diaphragm movement that we talked about, the inverted or paradoxical diaphragm movement, this was a very strong predictor of whether a patient felt better after the pleural aspiration. Okay, so that's the end of my talk for this morning. Just to summarize, normal pleural fluid drainage capacity is extremely large. We've talked about 2 or 3 liters per day, the maximum. Of course, effusion is the result of deranged physiology, but largely speaking, you'll be thinking about the parietal pleura and not the visceral pleura. And even if you see a small effusion, there must be very profoundly deranged normal pleural physiology. If you have symptoms of chest pain, always think about parietal pleural involvement, especially with pulmonary embolus and pneumonia. This should prompt you to look for pleural fluid and look to see if there has been any complications. Hypoxia should not be associated with pleural effusion alone. Now, patients with effusions are tachypneic, their saturations are slightly low. If they're profoundly hypoxic, you must think something else is going on and try and investigate that. Indeed, draining effusions in the absence of chronic lung disease for hypoxia is generally not a useful strategy. And then finally, the mechanism of dyspnea is because of thoracic compromise. And this means that when patients present with very large effusions, all we need to do is to decompress that extra positive pleural pressure rather than draining them to dryness. Thank you very much indeed for your very kind attention.